Let's talk about rheumatic fever. So, rheumatic fever is one of the diseases known as valvular heart diseases because it affects the valves. And for valvular heart diseases, we can classify them into two, those that cause stenosis and those that cause regurgitation. So if we say stenosis, we just mean that the valve is narrow and it is stiff, like there is a problem in opening. And now you know what? If there's something that has got difficult, that's something that is stiff, it is not just difficult in getting to poo. The problem is that even when it is pulled, it is very difficult for it to come back. It is stiff. So there's a problem in opening and there's also a problem in closing. That is because there is a narrowing and stiffening of the valve. So some of the causes of stenosis, what can cause the valve to be narrow and stiff is rheumatic heart disease. You also have got congenital causes like tetralogy or Fallot. You have got infective endocarditis. You have got carcinoids and calcinosis where there is calcium deposition into these valves. So for regurgitation, regurgitation just means blood is going back through a valve, and that is because the valve is incompetent. It can't close well, so blood is ending up going backwards. The causes of regurgitation includes all the causes of stenosis. Okay, all the causes of stenosis meaning rheumatic heart disease, congenital problems like tetralogy of Fallot, infective endocarditis, calcinosis, but also including heart failure. You know, in heart failure, blood can start going backwards. Dilated cardiomyopathy, ischemic heart disease, also known as acute coronary artery syndrome. For example, myocardial infarction and stable angina. And then you also have got other congenital problems like Ibstein abnormality, even the complications of endocarditis. What happens is that if there's inflammation of the endocardium, the papillary muscles that hold these valves or the chordae tendineae, they can end up rupturing. So the complication like the papillary or conde rupture, chordae tendineae rupture can result in regurgitation. So most common problems that affect the valves are actually going to be on the left side of the heart. We have got aortic stenosis, mitral stenosis, mitral regurgitation, aortic regurgitation. So basically, you are talking about either stenosis or regurgitation. You know, on the left side of the heart, you have got the aortic valve there and the mitral valve. So aortic valve, mitral. So the aortic valve can either be stenosed or it can undergo regurgitation, can be allowing blood to go backwards. Same with the mitral valve. So these are the common ones. And the abnormal valves, because they're abnormal, they disturb the flow of blood. So blood will not be able to flow normally, and because of the abnormal flow of blood, blood is not moving in a straight line. It is turbulent. It leads to a murmur or auscultation. Okay, and some of those murmurs you can actually feel them when you palpate as a thrill. So these are some of the things that you'll be getting when you are trying to take an exam of someone that has got rheumatic heart disease. These palpable thrills and then the murmurs. Now, murmurs may sometimes be heard with normal hearts. So, not every murmur that you hear is symbolizing that there is a problem. So, we call those as innocent murmurs. They reflect hyperdynamic state. For example, pregnancy, anemia, thyrotoxicosis, we call this hyperdynamic state. So that you can get a murmur. Benign murmurs are soft, short, systolic, and may vary with posture and are not associated with signs of organic heart disease. Benign murmurs, these are not problematic ones. So, diagnosis, when you want to diagnose a dysfunction of a valve, you can do it clinically or using echocardiogram. And to tell how bad the problem is, you use Doppler echo, which will measure the direction and the velocity of blood flow and allows a calculation to be made of the pressure across that valve that has got stenosis. So, diving in into rheumatic fever. Rheumatic fever is an inflammatory disease that has its first onset between the age of 5 and the age of 15. And it comes about because someone was initially infected with group A beta hemolytic streptococci. It is thought to develop because of autoimmune reaction triggered by the streptococcal rather than direct infection of the heart. So streptococcus, once it infects us, it's not that it is destroying the heart itself, but there is an autoimmune reaction. The body is trying to produce these antibodies against the streptococcus, the bacteria. But then the thing is that it contains antigens that are similar to the antigens on our heart. So those antibodies end up destroying our heart valves. Okay. So it's actually an autoimmune reaction between the antigen, the M protein of streptococcus hemolyticus, and cardiac myosin and sarcolemma membrane protein. So on the heart, we have got this cardiac myosin. You know, myosin is a contractile protein, and the sarcolemma membrane protein laminin. So these guys are similar to the M protein of streptococci. So once antibodies are produced against this, it will end up destroying the cardiac myosin and sarcolemma membrane protein. So the natural progression is first someone has got a sore throat or scarlet fever, which is caused by beta hemolytic group A streptococci. So what happens is that after 2 to 3 weeks, some books you see 2 to 6 weeks, so we can take a range 2 to 6 weeks, or we can simply say 2 to 3 weeks. So after 2 to 3 weeks from the time that you had a sore throat, some people may end up developing rheumatic fever, and this normally happens in children between 5 and 15 years. If this rheumatic fever is not well treated, not well managed, some few decades later, for example 10 years, 20 years later, what will happen is that rheumatic fever will now get to involve the heart valves, and so it becomes a rheumatic heart disease. So rheumatic fever plus the presence of valvular disease, that is rheumatic heart disease. And rheumatic heart disease, the most commonly affected valve is the mitral valve, followed by the aortic valve. Remember, we said this more on the left. And then you have got the tricuspid and then the pulmonic valves. What are the clinical features of someone that has got rheumatic fever or rheumatic heart disease? Remember, rheumatic heart disease, it means there's involvement of the heart valves. So the disease so a patient is going to present suddenly with fever, joint pains, and loss of appetite. In other words, there is joint pain and then there are B symptoms. Sometimes loss of appetite is considered a B symptom, but not really. It is actually, when you are clicking, it's part of the GIT when you are doing the review of systems. Okay, so fever, joint pains, and appetite suddenly presents with that. The major clinical features of rheumatic heart disease or rheumatic fever, you have got a changing or a new heart murmur. Okay, that is because in this condition you are really affecting the endocardium, and so there is an effect on the valves that disturbs the blood flow that results into a murmur, the most common being mitral and aortic. Okay, so heart failure and chest pain can be caused by carditis affecting all the three layers of the heart. And one thing we need to know here is that there's actually going to be panicarditis. There's the involvement of all the layers of the heart. There's going to be endocarditis, myocarditis. There's also going to be pericarditis. So if there is the involvement of all these layers, it can result into chest pain. Another thing is there's going to be polyarthritis, inflammation, and this is fleeting and affecting the large joints. Okay, polyarthritis. Mm, a lot of joints are going to be involved. Please take note that the joints affected are the large joints, not small ones. And then you also have skin manifestations like erythema marginatum, where you're going to have these transient pink coalescent rings which will develop on the trunk. And also you're going to have the subcutaneous nodules which are non-tender. And then there's also going to be Sydenham's chorea, which is also known as St. Vitus dance, because there's involvement of the central nervous system also. So this is erythema marginatum. These are the subcutaneous nodules, the mostly happening where you have got the tendons. Okay. So in diagnosis of rheumatic heart disease, we use the modified Jones criteria, and in the modified Jones criteria, what you need is to get at least two major criteria or one major and two minor. That's the criteria. Two major criteria or one major and two minor. On the major criteria, we use the acronym SPACE, S being subcutaneous nodules, P being pancarditis, that means there's endocarditis, myocarditis, and pericarditis. The A is arthritis. Specifically, this is fleeting, it is migratory. Like the patient is going to describe, I was first feeling pain in these joints on my, let's say, elbow joints, and then from the elbow they went to the shoulder joints. So it is migratory, it is fleeting, all right, and it is involving the large joints. And another thing is that this migratory polyarthritis is also going to be bilateral, it's on both sides. And then the C is Korea, specifically Sydenham's Korea or St. Vitus dance. And then the E is erythema marginatum. On the minor criteria, what happens that the patient is going to have fever. Remember what we said is that the patient is going to present with fever, loss of appetite, and then they have got a arthritis or polyarthritis. So fever, temperature greater than 38 degrees. There's also going to be elevated erythrocyte sedimentation rate, elevated the C-reactive protein, prolonged PRI interval, and then there can also be one joint affected, monoarthritis, or also poly. Actually, this is arthralgia. There is pain in one joint or pain in a lot of joints, mono or polyarthralgia. There is also going to be prior history of rheumatic fever and evidence of preceding streptococcal infection. So someone should tell you, okay, sometimes they might not remember because it's been many years, right? Or a lot of weeks. So they might forget that they even had a sore throat. But probably you can ask them, have you had a sore throat? If they can remember, they'll tell you. But there should be evidence of preceding streptococcal infection. So what are the signs? Because we've said that there is pancarditis. So if someone has got endocarditis, what will be the signs? There's going to be a soft heart sound, pansystolic murmur, meaning that this murmur is heard throughout, whether in systole or diastole, there's going to be this murmur because of mitral regurgitation. There's also going to be a mid-diastolic murmur, Kari-Cobb's murmur. There's also going to be early diastolic murmur due to aortic regurgitation. The signs of myocarditis is someone is going to have tachycardia, because remember, the muscles of the heart, that's where you find also the conduction system. The conduction system of the heart is not nervous system, it's actually muscle. These are specialized muscle, okay, where you are finding the SN node, the bundle of his, those are specialized muscle and not nerves. So I've got tachycardia, I've got also a soft heart sound, S3 gallop. And for this S3 gallop, we're going to pick it when we are scouting. When you feel on the mitral area, the aortic area, you go to the pulmonic area, the tricuspid area, and then you're going to ask the patient to move on the side. Okay, and then you feel the stethoscope on the apex while they move a bit on their side, they sleep on their side, you get the S3 gallop. There's also going to be cardiomegaly if there's the involvement of the myocardium, and the features of heart failure because of myocardial involvement. The signs of pericarditis, you have got a pericardial rub. Okay, so patient will complain of chest pain, and then pericardial effusion where there is fluid in the pericardial space. What are the investigations that we do in someone that has got rheumatic fever or rheumatic heart disease? Number one, you want to do a full blood count. Remember from the minor criteria, we said that there's going to be erythrocyte, a raised ESR. So you're going to do the erythrocyte sedimentation rate to see if it is raised. There's also going to be the white blood cells being raised. So we are going to see leukocytosis on full blood count. The diagnosis is based on the revised Duquette-Jones criteria. So the Jones criteria, remember for infective endocarditis, we use the Dukes criteria. This is Duquette-Jones or Jones criteria. So what you do is you look at certain clinical features and then the evidence of recent streptococcal infection. The treatment of rheumatic heart disease, So remember, we've talked about the three for the natural progression. It starts as a sore throat, and then rheumatic fever, and then rheumatic heart disease. So for the sore throat, you give benzyl G, basically a penicillin. So benzyl G start, you start with that one, and then you give oral pen V. You can also give augmentin, erythromycin, amoxicillin, or clavulanic acid. Because when you are giving this penicillin, you always combine them like that for 10 days. So basically, to treat the sore throat, you are giving penicillins. Rheumatic fever, to treat this one, treatment is with complete bed rest and high dose aspirin. Okay, so you can give oral phenoxymethylpenicillin for 10 days or a single injection of benzathine penicillin, 1.2 mega units. Erythromycin can also be given if there is allergy to penicillin. So what we are simply saying is that to treat this one, complete bed rest, high dose aspirin. You also give penicillins. Okay, in this case, you are giving the benzathine penicillin or benz penicillin. If you have got allergy to penicillin, give erythromycin. Because we said that there is chest pain, to relieve that chest pain, give an analgesic, for example, aspirin. Okay. And then other treatments, you are going to treat the other complications. For example, if there is heart failure, you're going to give the diuretics, digoxin. If there is pericarditis, okay, pericarditis that was causing a pericardial rub that was presenting with chest pain and pericardial effusion, can give NSAIDs. For carditis or severe arthritis, you can see there's inflammation, you are going to give prednisolone. And then for chorea, which is the involvement of the central nervous system, you give diazepam, a benzodiazepam for mild cases, and then you can give haloperidol when if there is a severe case. You also treat other complications like valvular lesion, heart block, arrhythmias. For rheumatic heart disease itself, rheumatic heart disease can be classified if it is mild or moderate to severe. So the mild, if there's mild stenosis of the valve, you just follow up. If there's moderate to severe involvement of the valve, you treat the valvular pathology by surgery. Okay. So let's do a question. A 24-year-old female presents to UTH with a 2-day history of severe joint pain. Initially, it involved the right knee joint, but then sequentially the right ankle, left knee, left ankle, and elbow joints were involved. The joints are swollen, red, and very painful, even with mild movement. Smaller joints are not involved. The patient also complains of fever, which is high grade, continued, and reduces with antipyretic drugs. She also complains of profuse sweating, palpitations, chest pain, malaise, fatigue, weakness during her disease period. What is your definitive diagnosis? Give three differentials. What other things will you ask in the history? What physical findings will you look for on examination? Give the natural progression of this condition. How do you diagnose this condition? What is the pathogenesis of your definitive diagnosis? How can you manage this patient? So, starting with the definitive diagnosis, you can see severe joint pain. Initially, it involves the right knee joint, but then sequentially the right ankle. You can see that it is migratory, right? And these are big joints that are being mentioned. And specifically, it has been mentioned small joints are not involved. Okay, and then the joints are swollen, red, and very painful. The red there, that's what is that telling us about? The joints are swollen, red, and painful. So there's arthralgia. Even with mild movement, the smaller joints are not involved. The patient also complains of fever, it's supposed to be greater than 38, and it's high grade, that's greater than 38, really high. Continued and reduces with antipyretic drugs. So if you give some drugs, it feels better. There's profuse sweating, palpitations, which is also a sign, chest pain, malaise, fatigue. So these are B symptoms. Our definitive diagnosis is going to be rheumatic fever. What are the other differentials we can give? So someone comes and they are complaining of uh, pain in the joints. What are the differentials that we can really think of? Okay, so we can have infective arthritis, which is caused by viruses or bacteria. Juvenile chronic arthritis, but specifically the juvenile one is for children less than 16, but this one is greater than 24, is 24 years. So that's why juvenile chronic arthritis can be a differential, but is not most likely because it affects young children. And then systemic lupus erythematosus can also be a differential because it also involves a lot of systems in the body, including the joints. Seronegative arthritis, like reactive arthritis, Reta syndrome, and rheumatoid arthritis can be differentials. What other things will you ask in the history? Okay, so what do you think we are going to ask in this patient? We are going to ask of history of abnormal or involuntary movements. That's chorea. Is there any prior history of fever or a sore throat? That is scarlet fever. You ask about palpitations, of which the patient already complained of that. There's already palpitation there, okay, and chest pain because of carditis. So to rule out systemic lupus erythematosus, because it's one of the differentials, you are going to ask about a skin rash. Do they have a rash? They specifically what we call malar rash. And then are there mouth ulcers, alopecia? Are you losing hair? So it is important for you to understand to ask this because it will show that you really are trying to rule out something in the history. So if you've been losing your hair, that's alopecia. Are there menstrual irregularities? That's also a feature of systemic lupus. And to rule out another differential, which is reactive arthritis or Reta syndrome, you look at the triad of iritis or iritis. So there is inflammation of the iris, and then there's arthritis, and also urethritis, the irritation of the urethra. How are you pronouncing this one? Iritis. Okay. And then, but the patient does not have history of involvement of the eyes or urinary tract. Also, it occurs after an episode of diarrhea or urethritis, which are not present here. So, when you are trying to rule out Rhetta's disease or reactive arthritis, you are looking at the iritis, arthritis, urethritis. Okay, but the patient does not have the involvement of the eyes from the history, and there's no problem of the urinary tract. So that's why we've ruled out this condition. What physical findings will you look for on examination? So on examination, what are we going to be looking for? From the space. So there's going to be a mama that you are going to be looking for, and then migratory or fleeting, non-deforming polyarthritis. Please take note that the arthritis here, the inflammation of the joints, is non-deforming. If there is deformation happening, you'll be thinking of the osteoarthritis and the others. Okay, and it involves large joints. And then you also, when you do the temperature, you find that the temperature is high. You also see a skin rash, erythema marginatum, subcutaneous nodules are also some things you look for. Involuntary movements. You also look for signs of endocarditis, like for example, pansystolic mama, mid-dystolic mama, and early diastolic mama. And then signs of myocarditis, tachycardia, ST3 gallop, cardiomegaly. And the cardiomegaly you can tell when you do a chest X-ray. And features of heart failure. So what are the features of heart failure that you are going to be looking at? If someone has got, let's say the left side of the heart is mostly involved, right? If there is left side heart failure, it's going to be pulmonary edema that is going to result into dyspnea. There's going to be orthopnea. There's going to be PND. If it is right sided heart failure, then there's going to be things like ascites. It's going to be jugular venous distension. There's going to be pedal edema and such. And then signs of pericarditis, complaints of chest pain. Of course, that one you can get from history. Give the natural progression of this condition. We say that someone will start first with a sore throat, and then is going to go after 2 to 3 weeks if it is untreated. In someone that is 5 to 15 years, is going to now go into rheumatic fever. After decades later, so sore throat caused by beta hemolytic streptococcus. After 10 to 20 years later or few decades later, if rheumatic fever is not treated, someone now will have valvular involvement going into rheumatic heart disease. How do you diagnose this condition? So diagnosis involves the use of the modified Jones criteria. And in the Jones criteria, what you are looking at are the number one, you look at the major criteria where you have got S space. So you space subcutaneous nodules, and then the P pancreatitis, and then the A you have got arthritis. Specifically, migratory polyarthritis, and then you have got a C, which is Sydenham chorea or Sydenham chorea, St. Vitus dance, and then the E is erythema marginatum. On the minor criteria, you are going to have a raised erythrocyte sedimentation rate, a raised C-reactive protein, and also a prolonged PRI interval, temperature greater than 38 degrees. There's also going to be leukocytosis. What else is going to be there besides what I've mentioned? There's also going to be either mono or polyarthralgia. So those are the minor symptoms. So you need to have at least one major or two major, or one major and two minor. Okay. And then how do so what is besides the major and minor criteria, you also need to have evidence of streptococcal infection. Okay, supportive evidence of previous streptococcal infection. How do you tell that someone had the previous infection? They should be, at least they should tell you recent streptococcal infection and a sore throat, or history of scarlet fever, or they have got a raised ASO titer greater than 200, or other streptococcal antibody titer, the anti-DNase or anti-hyaluronidase, or a positive throat swab culture for the strep. So those should be there. What is the pathogenesis of your definitive diagnosis? So this condition is because of molecular mimicry. So there is these antibodies which are produced against the M proteins of streptococcus, but then they end up fighting they end up attacking our myosin, cardiac myosin cells, and then you also have the sarcolemmal membrane proteins being affected, and so that is how it results into this problem. How can you manage this condition? So how can you manage rheumatic fever? Basically give the penicillins, isn't it? So management, complete bed rest, very important, and then you give the penicillins. Okay, benzathine penicillin. And another thing is you manage the pain, you give aspirin, you also treat if there's any other conditions. So that is it for this discussion. Thank you so much for being present.